residents' optimal functional level and quality of life. Welcome to a presentation on pain assessment and management training for registered staff. This presentation has been brought to you by the Ontario Association of Nonprofit Homes and Services for Seniors. The objectives of this presentation is to improve and maintain a resident's optimal functional level and quality of life, to optimally control pain for all residents, to reduce the incidence of unmanaged pain, to ensure best practice interventions for residents with pain, and to monitor and track trends related to pain management. Let's discuss some of the myths associated with pain and the elderly. Pain is a normal part of aging. The elderly perceive pain to a lesser degree or sensitivity than young people. If an elderly person does not complain, then they are not in pain, and elderly patients should receive lower morphine doses than younger patients. Research says that approximately 25% of Canadians suffer from chronic pain. Chronic pain becomes more common as people get older. 50% of Canadians take analgesic for chronic pain. 45 to 80% of nursing home patients have substantial pain, and 25 to 26% of residents with daily pain receive no analgesia. Let's take a look at the definition of pain. Pain is what the resident says it is and exists whenever the patient says it does. Pain is an unpleasant, subjective sensory and emotional experience that is associated with actual or potential tissue damage or described in terms of such damage. The RIMDS definition is that pain that is reported is unrelieved pain. If the resident does not have any pain due to pain management, then it is coded as a 0 for no pain. This slide talks about pain pathways. Let's take a look at the first area, transduction. Noxious stimuli causes cell damage with the release of sensitizing chemicals. These substances activate nociceptors and lead to generation of action potential. The second area is transmission. Action potential continues from the site of the injury to the spinal cord, from the spinal cord to the brainstem and thalamus, and from the thalamus to the cortex for processing. The third phase is perception, which is the conscious experience of pain. Finally, modulation. Neurons originating in the brainstem descend to the spinal cord and release substances such as endogenous opioids that inhibit nociceptive impulses. There are several words that can be used to describe pain. Can you think of any? Let's review 3 types of pain. The first that we're going to look at is acute pain, which is of sudden onset and lasts less than 3 months or usual time of healing. It can range from mild to severe and decreases with time. The second type of pain that we're going to review is chronic pain, which persists after healing occurs. Pain can be disabling and accompanied by depression and anxiety. Let's take a look at neuropathic pain. This is pain that is initiated or caused by a primary lesion or dysfunction in the nervous system, which is the central nervous system and peripheral nervous system, stimuli abnormally processed by the nervous system. Neuropathic pain is usually described as sharp burning or shooting and is often associated with other symptoms such as numbness or tingling in the affected area. Neuropathic pain can be described in various sensations: burning sensation, throbbing sensation, a pins and needles sensation, a stabbing sensation, an electric shock-like sensation, a numb sensation, and a shooting sensation. The next type of pain that we're going to look at is referred pain. and this is a term used to describe the phenomenon of pain perceived at the site adjacent to or at the distance from the site of the injury's origin. This chart refers to sites of referred pain and shows you the organ and the areas of the body in which it affects. The components of effective treatment of pain include assessment, pharmacological and non-pharmacological treatment, and evaluation of effectiveness. The first component is pain assessment. Screening should be done daily and can be done during routine assessments by asking residents and substitute decision makers about the presence of pain, ache, or discomfort. A full assessment should be done using a pain assessment tool within 24 hours of admission. Also quarterly according to the RI-MDS 2.0 schedule, and when a resident exhibits a change in health status or pain is not relieved by initial interventions, for example, when the resident is diagnosed with a chronic disease. Some examples include when the resident states that he or she has pain, when they are diagnosed with chronic painful disease, when they have a history of chronic unexpressed pain, taking pain-related medication for more than 72 hours, has distress related to behaviors, for example, changes in anxiety level or facial grimace, and indicates that pain is present through family, staff, and volunteer observation. Some behavioral indicators include facial expression, such as frowning, tightly closed eyes, and grimacing, body language and movement, such as fidgeting, rocking, and rigid posture, as well behavior such as sleeplessness, decreased appetite, mood swings, and wanting to sleep all day. Let's review the dimensions of pain assessment. You're going to look at the type of pain, the onset of pain, the location, intensity, the quality, the frequency, the factors that precipitate and relieve pain, and treatments used, as well as the effectiveness. One assessment technique is self-reporting measures, the gold standard of pain assessment for residents that are cognitively intact. When the self-report option is not available, observation of the resident's behaviors and reports from family and caregivers are used. The behavioral measure, for example, for those that are cognitively impaired, is used in conjunction with self-report. It is used to assess pain in the resident that are unable to speak out or that are not cognitively intact. Refer to the pain indicator list for the cognitively impaired. Another self-reporting tool is the descriptive tool, such as looking at where is the pain. We're going to look at the letters P, Q, R, S, and T. The first is provocation, and what causes the pain, what makes it worse, and what makes it better. Next is quality, and what does your pain feel like? What words would you use to describe your pain? R is for radiating. Does the pain move anywhere? S is for severity, and how much does it hurt on a scale of 0, which is no pain, and 10, which is the worst pain. Finally, let's look at timing or treatment, and when did your pain start? How often does it occur, and how long does it last? There are a few pain intensity rating scales that staff can use to determine the level of pain with the residents. The first is the Numeric Rating Scale, or NRS. There is also the Visual Analog Scale, the VAS, the Verbal Scale, and the Facial Grimace and Behavioral Flow Chart. The simple descriptive pain intensity scale simply looks at this particular scale that's showing no pain from mild to moderate, severe, very severe, and the worst possible pain. The 0 to 10 numeric pain intensity scale looks at a scale from 0 to 10, 0 being no pain and 10 being the worst possible pain. The Visual Analog Scale, or VAS, looks at no pain to pain as it could possibly be. The Facial Grimace Scale scores the level of pain from 1 to 10 based on the caregiver's observations for the resident's facial expression. You can also do what we call a behavioral observation. Mild to moderately cognitively impaired older adults can report pain, so ask for self-report. Pain in cognitively impaired residents is measured through behavioral signs. This involves observation of specific, discrete behaviors that vary from the resident's normal behavior. It also includes observations from family or caregivers. Let's now review the pharmacological approach with pain management. For mild pain, the following non-opioids would be used: acetaminophen, aspirin, non-steroidal anti-inflammatory drugs. For mild to moderate pain, the following opioids would be used: morphine, hydromorphine, and oxycodone. For moderate to severe, you would use adjuvant drugs such as anticonvulsants and antidepressants. The non-pharmacological approach includes exercise, transcutaneous electrical nerve stimulation, or in other words, TENS, heat and cold, relaxation therapy, massage, acupuncture, and behavioral therapy. Exercise has a multitude of health benefits, such as improving your mood, combating chronic disease, promoting better sleep, and exercise boosts your energy level. The acronym TENS is the use of electric current produced by a device to stimulate the nerves for therapeutic purposes. TENS, by definition, covers the complete range of transcutaneously applied currents used for nerve excitation, although the term is often used with a more restrictive intent, namely to describe a kind of pulses produced by portable stimulators used to treat pain. Heat or cold is also a form of non-pharmacological approach to pain management. Distraction and imagery. Redirection on something and away from the pain. Structure technique that uses the resident's own imagination to develop sensory images that divert focus away from the pain sensation and emphasize other experiences and pleasant memories. The aim of relaxation is to free residents' anxiety and muscle tension. This requires a quiet environment, such as guided breathing and meditation. Let's take a look at a case study. Mrs. V is an 85-year-old woman who has just been readmitted to your long-term care home following a brief stay in an acute care hospital. Mrs. V has a diagnosis of dementia. Prior to admission to the hospital, she was mobile, but because of the dementia, she was unable to participate in her care and other activities of daily living. She was sent to the hospital because of a fall which resulted in a fracture to her left hip. When you receive the resident, she is moaning loudly, and her eyes are tightly closed. She is very rigid and grimaces when you attempt to move her in bed. Placing the resident on her right side and supporting her left leg appears to relax her, and the moaning is less intensive. Several of her children are at her bedside and look at you to help their mother. Indicate how you would assess her pain and what tools and observational skills would you use. How would you determine if the interventions you have tried were effective? Thank you for watching this ONUS presentation on pain assessment and management training. Let's now work together to ease the pain.